Well, thanks, Charlie. Appreciate the introduction, and it's a true pleasure to be here. I'm Jay Turner from the Barrow. I'm here with Rob Rudy, one of our sixth-year residents who's doing an in-folded fellowship this year, and we're just going to demonstrate the PTP technique. So we've got, just for orientation here, we've got the patient cadaver in a prone position. Cranial is to my left, caudal is to the right. We've placed some marks on the patient here. We're essentially working at the window between the iliac crest and the 12th rib. This is the disc space we've been working at. We are kind of navigating between a prior Coflex implant here, so we went a level up. We're at L2-3. We've started the approach here, made our skin incision, and did our retroperitoneal dissection here. Rob, if you want to come in. Essentially, the access, the key piece is ensuring safe access to the spine. Dr. Pimenta promotes a two-incision technique. This is when we showed this through a single incision, which is also safe for the appropriately selected patient. The importance for me is being able to actually tactilely feel the psoas muscle. If I can't touch the psoas muscle, I'll want to have another finger in there. And for larger obese patients, that could be necessary. As long as I can reach the depth and have good tactile feel throughout the retroperitoneum, I'm comfortable with a single incision. So here we've made our skin incision. We bluntly dissect through the abdominal muscular layers so that we don't have any inadvertent thermal injury to the nerves that run through the abdominal musculature. And what I like to do is palpate posteriorly to feel that quadratus laborum. You come down in a transverse process, palpate the psoas muscle, and then we'll dilate right over your finger. And by kind of maintaining contact with the abdominal wall down to the psoas, we know all of our retroperitoneal contacts will be anterior and will be safe, especially with the single incision technique. That's important. So we'll have Rob come in here and do that. And in general, with this dissection, you want to feel all the usual landmarks. You want to feel your transverse process deep, psoas muscle. You want to feel the inner surface of your rib, inner surface, the kind of a smooth surface of your iliac crest, and that way you know you're in the right space there. And once you feel all that, once you have your peritoneum free, we can begin with dissecting and start the dilation across the psoas muscle. So Rob's going to come in and do that dissection across the psoas muscle. And so he went in, maintained that contact with the abdominal wall. Now he's positioning it over what's the L2-3 disc space here. Shot. And there's different philosophies of where to dilate through the psoas muscle. I generally try to target it right at the 30-yard line and open anteriorly, unless I end up encountering some of the muscle fibers of the nerve where I need to dock more anteriorly. So it looks like he's in a good position there. And he's going to dock that with the K-wire. And these dilators have integrated triggered EMG, so you can map out your lumbosacral plexus, particularly the motor fibers, which allow this to be done safely, especially as you go lower in the spine, like at the L4-5 level. And so we want to see lower threshold posteriorly, higher threshold ventrally. At L2-3, you're not always close enough to motor fibers to get a low signal, especially at L3-4 and L4-5. And here I like to stick my finger in and make sure as anything passes in, kind of protecting yourself ventrally, make sure nothing gets trapped. And we're dilating up, dilating through that muscle. After the third dilator, the retractor is inserted.
Have that
Just attaching the A-arms to the retractor here. Somebody hold this up for me. Thanks. Okay, once that's locked in, now we can optimize positioning of the retractor, and we're essentially going to be looking at the dilators we're using to get, here, you can hold that, Rob, trying to get parallel to the floor. And if you have a good lateral x-ray, you're getting in line with your C-arm, and that should get you pretty close. You shot there? Shot? 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 It's getting pretty close. Shot? 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 There we go. We'll commit to it there just for sake of efficiency here. Okay, you can remove that. So now with our retractor locked to the table, we're going to remove those dilators. And the key with it, what's different with prone compared to lateral decubitus is you're essentially working 90 degrees to your normal working angle. So you're working 90 degrees to gravity, and everything likes to drop. And so everything has to be with that in mind as you're doing this procedure. So why don't you sit down, Rob, and you can look through there. And do we have lights? Mm-hmm. Can we swing this to an AP, please? Please. Okay, bring the lights about halfway down so they don't get obstructed. You can just do the one for now. Okay, do a shot there. Okay, can you rotate the bed a bit, please? So on the AP, you want to make sure your spinous process is midline. And we essentially, for the Transpsoas approach, want to be working exactly orthogonal, and we rely heavily on good X-ray. Do a shot, opposite way. You go the other way. Shot. Yeah, a little bit more. A little bit more. Okay, that's great. And essentially during the procedure, you want to be checking to make sure this orientation is not changing. The spine can rotate, and that's going to change your direction. All right, so we now have a retractor in. K-wire is still in place, which I like to use kind of as my North Star in there to make sure the retractor is not moved, especially in the prone position where things can drop. So you able to see in there, Rob? Where's that? Okay, good. Perfect. So then we'll come back to a lateral and confirm placement of our retractor. And we have a shim. Mm-hmm. Go posterior there. Okay. So at this stage, we want to, with our dilators, we stimulated, ensuring the motor fibers are posterior. Here, before we insert anything in there like the shim, we want to make sure that there aren't any motor fibers in our field. So there's a ball tip stimulator that we like to use, which we will pretend we're using. We want to ensure there's nothing in our field that could be damaged with the placement of the shim. And if we're satisfied.
So Jay, can you comment on the relevance of those triangles of the retractor?
Yeah, absolutely. Yeah, so that helps to maintain your orientation of your retractor. So ensure you have perfect lateral X-ray that helps keep you oriented. And so these are ways of ensuring the right retractor placement. We moved the table a bit after we had the retractor down, so they're not perfectly in view here. We could fiddle around with it to make those perfect for this shot, but we're going to just leave it where it is for now. But that's a good point. The retractor has kind of built-in checks to make sure you're where you want to be. Okay, so assuming, can we come back to a AP, please? So assuming we didn't have any positive signals in our field, I also like to visually inspect, make sure you don't see anything that looks like a nerve, and you have a good, clear view of your lateral annulus. We'll take a shot there in AP. No, yeah, once this comes out, you may be able to see a little bit better. Okay, we have a mallet. Good. AP? And can you pull back toward yourself? Shot. And pull back a touch more. Okay. So now that we have that posterior blade secured to the disc space, we can move the anterior blade. As Dr. Pimenta mentioned in his talk, we'll do 6 for an 18 or 8 for a 22. Yeah, we'll do 8. Okay. So 22 is the typical size I like to use. So at this point, we can pull that K-wire. There you go. And do you have like a Penfield 4 or some sort of dissector? Sit for a second, Rob. Just sit for a second. All right. And you have a couple different options with this retractor. You can also secure the anterior blade. Here we're just going to move on to our annulotomy. And so let me get the knife, please. Just want to leave a little cuff anterior to the posterior blade. And here the amount of retraction of the muscle and the lumbosacral plexus is really dependent on the efficiency, and so you want an efficient disc prep, and that doesn't mean your hands have to move quickly. It just means you need to have kind of consistent and efficient steps. So now we'll go to the cob. You want to make those annulotomy cuts nice and deep. And so after you make your annulotomy cuts, we'll mallet.
So Jay, what percent of your laterals are done in the prone position?
Yeah, it's become more and more as I become more comfortable with the prone position. I've been doing these in the prone position for 4 or 5 years, and I would say 80% of them I'm doing prone now. Let's get a shot, please. Okay, so you want to come back out a little bit. So, yeah. There you go. And so you just want to get this started in there, and then what I like to do is just kind of walk it down the end plate, shot. Yeah, we get a little bit of an end plate there. Shot. There you go. Why don't you walk that down now? Yeah, so essentially it's the same steps and the same comfort level as you get used to the difference in ergonomics. So I've become more and more comfortable with it and kind of slowly transitioned to do most of them this way.
And what I found is not wearing your loops is advantageous.
I agree, yeah. You're often having to tilt your head a bit. And once you get to that contralateral annulus, you want to mallet, so you want to support your hand there. Once you feel a little bit of loss of resistance, you know you're through. Not quite yet. A little bit more. A little bit more. There you go. Loss of resistance. Give it a little twist. And now do the other. Now you're getting hung up on the shim. The slap hammer. Yeah, come off a little bit. Yeah, really protecting your end plates is critical for these procedures, especially if you're going to be relying on indirect decompression. So you really want to respect that interface between the disc and the bone. Yep, that's good. And this patient's got an enormous disc, usually a little bit more degenerated and collapsed than a real patient. We'll go right to the box cutter from this point. And same thing, make sure you leave a little bit of cuff. Downward pressure. As you're malleting here, the retractor does want to push out, so the assistant should be kind of pushing the retractor in. Get a shot there before you go. Shot. Shot. Take it to lateral annulus on the contralateral side. That's good. That's good. Slap hammer. Downward pressure on the retractor. Good. And we'll get a pituitary. You have a larger one? Thank you. And where I think people lose a lot of efficiency is with the pituitary, trying to pick every fiber out. If it's stuck to the end plate, this is not going to come out very easily. So just a few swipes with the pituitary. Yeah, I think without getting much disc out, we'll probably want to pull a little more out. You have like a ring curette. Perfect. Just see if you can pull some disc out with that. And if there's still a big plump disc in there, your trial or your implant are going to really bounce. So we're going to pull some of that disc out. You can check your depth as well and get an AP shot when you're the other side. X-ray. Not good form to pull the contralateral plexus into your field. That looks good. Okay. Pituitary. And often you can use your box cutter as your trial, especially for collapsed discs. You can get a sense even before you really start your procedure what the implant is going to be that you're going to be using. Here we'll go through the motions and use the trial here. X-ray. Good. And really push down with your supporting hand. Avoid the bounce. Shot. Yep. Shot. Yep. And most of these implants have a little bit of a taper at the nose. To really get full support across the apophyseal ring, you want to pass past that taper. A little bit more. Good. And then come to a lateral. Okay, looks pretty good. Come back to an AP. All right, with a slap hammer. Good. And so at this point, we select our implant. I'm not sure what our options are back here. That's what we're going to use. Okay, so at this point, we're now going to prepare our end plate. So we don't want to go right from there. We haven't done any real end plate prep, so you can use a combination of curettes. I typically like this kind of ring curette stirrup, and then to get under the concavity of the inferior end plate of the level above, I'll get a up-angled curette. You have an up-angled version of that? Yeah, that's good. Often you have that concavity, and straight curette can be difficult to really clean all the cartilage off. And so now while they're kind of as part of the efficiency, while they're preparing the inner body, packing graft, because these are all peel packs, so that takes a moment to prepare the inner body. This is when we're cleaning inner body device, or the disc space there, so that we can place the inner body device. Okay, good. I typically stick a pituitary in there to clean anything else out. And then you want to make sure your graft is oriented properly, taller in the anterior aspect. Yep. Shot. Mm-hmm. Shot. Another shot. Okay, that's pretty good. And so you can see that taper sticking out the contralateral side. I actually like that. I like the mid portion of the implant being a little bit past midline, so you get that full support. And push that gold tab, turn it counterclockwise, pull out, another AP, and a lateral.
Any questions for Dr. Turner?
I have a
Yeah, go ahead.
Yes. Is it practical to do it in obese patients?
It's a good question.
Can you repeat the question? Sorry.
What is your experience in doing the prone transpsoas in obese patients?
Yeah, challenging initially. I think I've become more comfortable with it. I think there are a couple different challenges, particularly prone. One is you often get retroperitoneal creep with that retractor open. And so there's ways to mitigate that where you can wrap the retractor in a thin layer of ioband. It kind of stretches and protects your corridor a bit, which is very helpful. The other is the depth and be able to actually feel what you need to feel. I think to do this procedure safely, you can't be doing it blindly. You're not just sticking things in blindly onto the psoas. I want to feel the psoas. I want to protect everything. And if they're too deep and you can't get your finger down to the psoas, you have to figure out a way to make that happen or change procedures. So Dr. Pimenta talks about a second incision more posteriorly, which is similar to what we do for the lateral decubitus approach, where you actually get a finger that's deeper, starting more posterior, that you can use kind of to palpate things more easily. So I think with experience and some modifications, you can still do the obese patients safely, but I agree that it's more challenging, especially starting out.
Perfect.
You get a lateral. Yeah, a little on the anterior side, but pretty good.
Looks nice. All right. Well, thanks very much. I think we're catching up. We're running a little behind earlier, but we're almost.